So we're going to move on to the neck and cardiac exam. Your patient is already in the correct position for this, laying down with the head of the examining table at 30 degrees and the gown folded down over the abdomen for good exposure of the entire chest. This also obviously exposes the neck, and we're going to start by trying to assess the height and character of the jugular venous pulsations. We'll leave the fine points of the theory behind assessing jugular venous pulsations to the small group environment. But remember that with the patient at 30 degrees, we're hoping to be able to determine the highest point on the neck that jugular venous pulsations can be seen. And in order to do that, we're going to start by having our patient turn their head toward the side, and we're going to use tangential lighting to light the suprasternal area and the side of the neck, looking for the multiphasic jugular venous pulsations. I see them well here in the suprasternal notch. Looking up, I see them roughly to the mid-neck. Again, you're going to see them a lot better when you have you do this on your patient in the clinical science teaching area. So after assessing that, I'm going to try to assess them on the other side. Have the patient turn his head towards me. And again, look on the other side in the suprasternal area and then higher on the neck until you get a sense of where they disappear. Good. And your patient can straighten their head out again. The next step is to feel for the carotid pulsations. This is medial to the sternocleidomastoid and low on the neck. You feel one side and then the other, comparing the pulsation and strength of that pulsation. After feeling for those pulsations, you'll listen for them with your bell. And during the time that you're auscultating, you want the patient to hold their breath, so you'll need to give them directions to do that. So you want to make sure that you're on your bell. I usually do this by tapping my diaphragm to find that I'm on the diaphragm side and then switching. You'll lay your bell down where you palpated. Can you go ahead and hold your breath for me? Breathe, and then listen on the other side. Hold your breath, please. And breathe. Good. The low-pitched sounds of a bruit are usually best appreciated with the bell, and the other thing is that the bell fits a little better into that small space in most patients' necks. So you will use your bell to listen for carotid bruits. Now you'll move on to inspection of the anterior chest. You've inspected once during the lung exam, but now you're looking for different things. You're going to take out your pen light, and using tangential lighting, you're going to be looking for the point of maximal impulse, or the PMI. You expect to find this at approximately the 5th intercostal space, mid-clavicular line. But it may be inside that or outside that, especially in a disease state. Use your tangential lighting to look over the chest wall. See if you can see the PMI, and then once you've found it, you can go ahead and palpate over that area to characterize it. You're feeling for size, impulse strength, and duration. Now in this patient, it's right at the midclavicular line in the 5th intercostal space, but you could feel in any given patient all the way across in the 5th intercostal space and then actually out into the anterior axillary line to try and find it if you weren't able to find it. After you have felt that PMI and characterized it, you are ready to auscultate the heart. In order to do that, you have to be very clear about one most important landmark, and that's the sternal angle. The suprasternal notch is the notch right above the manubrium, and then where the manubrium and the sternum connect is the sternal angle. The sternal angle is opposite the second rib, and therefore the second inner space, the second intercostal space, is just below that second rib. That's where you'll begin your auscultation. So on every patient, you'll want to feel for that sternal angle. It's kind of a bump. Go straight across and then slightly under, and you'll be in that second intercostal space. That is the aortic area. So you have the aortic area, pulmonic area, moving down the left sternal border into the fifth intercostal space at the lower left sternal border. You have the tricuspid area, and then moving across to the midclavicular line in the fifth intercostal space, you have your mitral area. And those are the guideposts for your auscultation. You will listen with the diaphragm, second right, second left, third left, fourth left, fifth left, move to the fifth midclavicular line, move out to the fifth in the anterior axillary line. You'll then go back to the third left intercostal space, have your patient sit up and listen with the diaphragm, lay your patient back down. With the bell, you will start in the third left intercostal space, fourth, fifth, move to the midclavicular line, then turn your patient into the left lateral decubitus position, roll them over, listen, and lean them back. And we'll go through that right now. First of all, make sure that you're on your diaphragm. Find your sternal angle. Sometimes helps if you find the sternal notch first, then feel for that sternal angle. Move straight across and underneath to the right second intercostal space and just lay your diaphragm over that. Aortic area, move to the second left intercostal space, pulmonic, third left intercostal space, this is also called Erb's point, fourth left, fifth left, this is the tricuspid area. You'll move across towards the midclavicular line in the fifth intercostal space to the mitral area, and then move into the anterior axillary line to listen for any transmitted sounds. While you still are on your diaphragm, you'll go back to your third left intercostal space and ask your patient to sit up. You sit up for me and lean forward and exhale. Go ahead and breathe and lean your patient back down. That's listening carefully in Erb's point for any soft aortic sounds. You'll then switch from your diaphragm to your bell. Again, start in that third left intercostal space, or Erb's point. Listen fourth, fifth, move into the midclavicular line in the fifth. And now you're going to turn your patient into the left lateral decubitus position. To do that, ask your patient to take this arm and put it behind their head. And then you roll the patient carefully on their left side and listen, inching back to the lower left sternal border. Good. And then you can roll your patient back. That basically completes the auscultation sequence for the cardiac exam. The steps are not the difficult part here. What's difficult is interpreting what you're listening to in your head. So the equipment is not complicated like the ophthalmoscope or the otoscope. It's more getting used to listening for the heart sounds and getting an organized approach to listening to their quality and their characteristics.